So I'd like to thank the organizers for inviting me to talk on basic concepts on inflammation, linking it to aging, both in people with and without HIV. Here are my disclosures. Now to start, one can ask how inflammation causes aging, and the truth is we don't really know, but in the next 14 minutes, I hope to bring you up to speed on what we currently understand about this process. So we need to start with Claudio Franceschi's seminal paper on inflammation, where he coined that term. And it starts with an understanding that we have in all of our tissues an anti-aging cellular defense network that's set up to respond to all sorts of different stressors, be they infectious or cellular damage. And it really is resistance to stress that underlies our ability to survive, a direct quotation from this paper. And how does inflammation fit into this? Well, inflammation is a conserved response to stress of any cause. And so it can be an infection, it could be oxidative damage from radiation or thermal injury. All of those will induce an inflammatory response. And this is important to realize because inflammation is a normal process and is probably a very adaptive response that helps clear infections and repair damage. Claudio makes a point in this initial paper that IL-6 actually increases with age, primarily as a consequence of these cumulative stressors, but this even occurs in healthy aging. In fact, many centenarians with healthy aging have abnormally high IL-6. And so they put forward this concept that you need a second hit, not just these inflammatory insults, but also maybe the absence of a protective factor, maybe a genetic factor that decreases one's likelihood of developing frailty, for example. That you need that second hit in order to get disease manifestations and an unsuccessful aging phenotype. And this theory was further developed in later papers where this concept came forward that inflammation is protective early in life, but detrimental later in life. It may be that having a robust inflammatory response is really protective against infections, the leading cause of death among young people, and that may promote, that may be evolutionarily conserved as a consequence of that. But a consequence of that may be that as you get older, beyond your reproductive years, that chronic inflammation may contribute to damage in the tissues and unsuccessful aging, such that later in life, it may be more helpful to have these anti-inflammatory factors around. The key here is that evolution only cares about selective pressures present during the reproductive years. So if inflammation is causing heart attacks and cancers later in life, evolution doesn't care. It only cares about the impact of inflammation on things that kill you before the age of 50. And so this may be why inflammation has been so highly evolutionarily conserved. And still, this concept was further developed with the idea that acute inflammation is really an adaptive response that helps repair wound healing. It helps respond to infections and clear them, whereas chronic inflammation is maladaptive, regardless of the inflammatory stimulus that leads to chronic inflammation. You may have over time ongoing damage in multiple end organ tissues, leading to chronic disease if it's not resolved. And so how does this work? We don't really know how inflammation really leads to tissue damage and the aging phenotype. But a key concept is outlined here that chronic inflammation really impairs the response to stressors. And so in acute inflammation, your cells respond and then they return to a resting state where they can respond again. But if you have chronic inflammation, your cells are constantly responding to stimuli. And when they've done their thing in vivo, they can't respond again. We see this all the time in immunology. If a T cell, for example, has responded to its cognate antigen in vivo and divided multiple times, if you take it out of the blood and stimulate it with that antigen again in a cell culture, it doesn't divide as much just because its telomeres are shortened. It's already done its thing in vivo. And this concept plays out in all sorts of cell types, where if you've had lots of cellular signaling over time as a consequence of inflammation, your ability to respond to new stimuli gets impaired over time. And so that's the basic concept of how inflammation may lead to dysfunction in tissues. And if we put this back in the context of that cellular defense network, it could be that inflammation, acute inflammation, is a response to stress, but that chronic inflammation actually impairs the response to stress. So it may be, just like any one of these oxidative insults or physical damage in and of itself. And so this leads to the 7 pillars of aging, which have been put forward in the geroscience literature. This review that came up with the 7 pillars was put forward by the National Institute of Aging as a way to sort of add credence to all of the key mechanistic pathways that appear to contribute to aging in animal models. And it's a little bit like asking a parent to choose the child that they love the most. Of course, they love all their children. And so all of these pathways are highlighted and are interconnected in this model. But where the model falls down is that it doesn't necessarily suggest, where is best to intervene. Do I intervene on inflammation? Do I intervene on metabolism? It's tough to know looking at this model. And so, which is why in the HIV field, we and others have put forward a tree analogy where there are distinct root drivers of the inflammatory state and inflammatory pathways that may go on to predict disease, highlighting discrete interventional targets that we could pursue. I think we ultimately, if we need to translate these findings, we need to think this way in terms of where best to intervene. Now we know that inflammation is a cause of aging now from the Canto study by Paul Ridker and colleagues. They gave the IL-1 beta inhibitor canakinumab a pure immune-based intervention to people who had pre-existing heart disease and showed that it clearly decreased inflammation by CRP here, and it also decreased cardiovascular event rates significantly. Lung cancer mortality also was decreased significantly in this study. And so this really proved for the first time that inflammation can be a cause of chronic disease risk. On the other hand, they showed that there was an increase in death from sepsis in people who got canakinumab. Even though overall it was protective, there was an increase in infection-related mortality. And so this is a key reason why we're not using canakinumab in the clinic now in a lot of patients with heart disease, because there are these competing effects. Even 5 years after this study was published, this has not been endorsed as an effective therapy to use in the clinic. And so this has been studied in the context of HIV as well by my colleague Priscilla Hsu, where she's shown that IL-1 beta inhibition does decrease inflammation here by IL-6 levels, also in the vascular tissue. But there are concerns that it didn't affect all pathways of immune activation that are abnormal in people with HIV, in particular T cell activation, and that and there are concerns that perhaps there are other parallel pathways of inflammation that are not targeted by this approach. And then lastly, people with HIV already have an increased risk of infectious complications. And so there remain concerns as to whether IL-1 beta inhibition might not be perfectly safe in people with HIV. And so, so this intervention hasn't really moved further forward in the HIV field. And this highlights what I like to call the whack-a-mole problem of immune-based interventions, is that they may not block all important inflammatory pathways. There may be parallel inflammatory pathways that are driving disease, and blocking one may also sometimes make others worse. And it may also interfere with immune defenses that might increase infection risk. And so these are the considerations we need to worry about when we're thinking of intervening on the immune system itself. And this is why many of us in the HIV field have really focused on some of the root drivers of inflammation, HIV reservoirs, CMV, microbial translocation. And we do have, while we don't currently have any therapeutics that block HIV expression from cells, those are interventions I think that we definitely need in our field to reverse one of the key putative drivers of inflammation in treated HIV. But we do have interventions that can deal with asymptomatic CMV replications that we're currently studying, letermovir in the ACTG. And Janet Lowe's group also reported some very encouraging data on GLP-2 agonists at CROI earlier this year, showing that they can decrease inflammation from microbial translocation. And so we're making progress in some interventions directed at these root drivers. One thing I'd like to note is that the disease-specific manifestations may be related to the anatomic localization of the inflammatory stimulus. So it could be that the diseases that CMV is inducing may be distinct from the diseases that HIV is inducing directly. And so we need to be open to that concept moving forward. And then lastly, senescent cells themselves may drive inflammation. So senescent cells develop in response to chronic stressors like inflammation. But then once you've developed a senescent cell, there's this senescence-associated secretory phenotype whereby these senescent cells become a cause of inflammation. They secrete inflammatory cytokines contributing to tissue damage. And so there's been a huge development in the aging world to actually target senescent cells themselves with senolytic drugs that may clear them from the tissues and hopefully decrease inflammation and decrease the frailty phenotype. And there's actually good data now in humans that some of these agents like dasatinib and quercetin can actually decrease senescent cells in people. And we know in animal models that these cells may contribute to decreased longevity. And so there are now protocols to test these senolytics in people with HIV in the ACTG. So to conclude, inflammation is the evolutionarily conserved response to stress. It's adaptive early in life and helps to resolve infections and heal damage. But chronic inflammation may be maladaptive later in life, decreasing responsiveness of cells and impairing response to stress. And inflammation is actually causally associated with chronic disease, but the optimal targets to intervene on inflammation remain uncertain, particularly in the HIV world. Intervening on the root drivers of inflammation is sensible, in particular microbial translocation, CMV, and then if we can develop interventions to decrease HIV expression from cells. And then also intervening on senescent cells also makes sense, but the extent to which senescence explains inflammation in HIV is still unknown. And so we hope these new studies in development now shed light on that. So thanks for your attention. I look forward to your questions.